One of the most universal tools for a medical professional in any kind of monitoring or emergency situation is non-invasive blood pressure monitoring with ECG or without. Without, we normally call it a vital signs monitor, and we call it a patient monitor, generally when you have ECG, a minimum of a 3-lead or 5-lead ECG. So non-invasive blood pressure is measured routinely throughout the course of nearly all medical procedures and diagnoses, and it reveals the efficiency or impairment of the circulatory system, so the hemodynamics and the function of the heart. So thinking of the heart as the engine of the car, is basically the engine tester, that without the heart, you don't have anything else functioning, although the heart and the circulatory system must work together to oxygenate all tissues to keep all organs working. But it can also reveal internal bleed, shock, and other events that aren't directly related to, for instance, respiratory. So it really is an indicator of the hemodynamics of the blood and the heart. So it's reported as systolic over diastolic, and systolic being the peak pressure, diastolic being the lowest pressure that is due to the cyclic action of the heart pumping. And then it also can measure the mean pressure or the average pressure. So the pulse oximeter levels, they depend on both the respiratory and circulatory function. So they can't diagnose specifically whether the problem is due to hemodynamic impairment or respiratory impairment. So the blood pressure gives that extra information to tell you how the hemodynamics, how the circulatory system is contributing to the patient's current condition. NIBP analyzers are quite expensive. ATC Labs does have one at $2,500. They are a bit difficult to connect because everyone's blood pressure cuff is a little bit different. There needs to be different fittings, and that is not part of this seminar. We did do that training in a prior seminar. The most common NIBP monitor problems are either leaks or operator error. Many times, if the cuff is not positioned at heart level, you will either get a value that is too large or too small. Alarm levels are sometimes set incorrectly. Cuff size can contribute to errors. And then, of course, there are problems with battery, and potentially the pump and the valve can fail. So here's just a brief review of how a non-invasive blood pressure monitor works, which is very similar to the way in which a nurse would take blood pressure. The cuff is inflated, in this case automatically, until the blood is completely shut off at above the elbow, and then the pressure is released until the first signs of blood getting past the cuff down to the hand are detected, and that is detected in an automatic blood pressure monitor by a high-pass filter which extracts an oscillation which is listening to when the blood first starts to spurt past that cuff. Now that's a systolic level. It only happens at the peak pressure of the heart. As the pressure continues to go down, more and more blood spurts past the cuff, making a larger and larger oscillatory signal until all of it gets past at a very low pressure, and that is the diastolic pressure. That is the least amount of pressure exerted by the heart. By looking at that pattern, the envelope of that oscillation over time, the blood pressure monitor can compute not just the systolic level and the diastolic level, but also the mean level of pressure, which is something that is not typically able to be determined by a nurse. So again, in summary, the cuff automatically inflates to a pressure necessary to occlude or stop the arm's arterial blood flow. The cuff pressure is slowly reduced until it falls below systolic pressure determined by the pressure transducer high-pass filter. The cuff pressure oscillation occurs as arterial blood breaks through the occlusion at systolic pressure, continues until the cuff pressure falls below the diastolic pressure, again derived from the pressure transducer high-pass filter. Then the oscillations cease, and the mean pressure can also be derived from plotting the oscillation envelope versus pressure. Testing an NIBP monitor without a simulator is very difficult, and even with a simulator it's very involved. But without a simulator, all the technician can do is take their own blood pressure and compare it to what they might get on a machine that they consider reliable and calibrated. However, unless the technician has high blood pressure or low blood pressure, they're not going to be able to test the levels when we're most concerned, which is those abnormal levels of blood pressure. They may be able to do 120/80 if they're in good health, which is typical, but how would they determine whether or not the blood pressure monitor is accurate at, say, 200/120? You can't make your blood pressure go up that easily. So there's huge disadvantages in human subject testing. But fortunately, there aren't too many things that can go wrong with a blood pressure monitor, except, of course, for leaks. And leaks are one of the major problems. Again, the most common problem is misuse or misunderstanding by the operator of how a blood pressure monitor works. So, for instance, if the cuff is not at heart level, you will get a different reading than an inaccurate reading. So one of the most unreliable types of blood pressure monitors is a wrist monitor, because if you hold the wrist even a few inches above the heart, the pressure will be reported as too low. If you hold the wrist below the heart, the pressure will report as too high. And it will be very difficult, for instance, with a wrist blood pressure cuff, automatic cuff, to get a reliable reading. The same problem can happen with an arm cuff if the nurse or clinician is not careful about the position of the arm to make sure that the cuff is actually exactly at heart level and not changing. Now, this is easier if a patient is lying down in bed and prone, because the cuff will generally be right at the level of the heart. So in summary, the NIBP monitor is one of the most critical pieces of equipment for a clinician. It gives critical feedback of blood flow hemodynamics created by the cardiovascular system with the heart as its engine. And together with pulse oximeter, it can help diagnose both cardiovascular and respiratory failures. Either one alone is not enough to determine the respiratory and cardiovascular health. So the two are needed together. And the non-invasive blood pressure monitor is an automated version of the traditional method of determining blood pressure, but it does allow an additional measurement called mean blood pressure, which is not something the nurse can normally compute. NIBP calibration requires expensive pneumatic simulators, which are beyond the reach of most hospitals because they are in the neighborhood of over $2,500. Fortunately, most of the faults which are involved with NIBP monitor are things like end-of-life batteries, leaky hoses and cuffs, the wrong cuff being used, faulty hose connectors which allow leaks. So basically checking all electrical and pneumatic connections. But most importantly, it's also true that the operator has to understand that the cuff must be maintained at heart level. And so certain types of cuffs, such as wrist cuffs, are not useful because they are seldom able to be controlled right at heart level. Transport ventilator is a very complicated piece of medical equipment that requires an understanding of both fluid dynamics, pneumatics, and thermodynamics. The physics is very complicated, but fortunately, there are very few things that can go wrong with it, aside from checks on filters and operation. But we will briefly discuss it and then have a complete PowerPoint tomorrow discussing this very complicated topic. So far in respiratory distress, we've discussed the very important topic of getting oxygen to the brain, because oxygen to the brain is vital within minutes or the brain starts to die. But that is not the sole function of respiration. The other thing respiration does is to get rid of carbon dioxide in the bloodstream. And over time, the buildup of carbon dioxide or the excessive release of carbon dioxide in the bloodstream can cause other serious problems. Now, oxygen is still the most important short-term thing. We also depend for supplemental oxygen on the ability of the patient to be able to inhale and exhale. If they are only able to inhale, exhale in a compromised fashion, then maybe just adding oxygen will help them. However, that supplemental oxygen will not work if they are not able to inhale and exhale, and that's where the role of the ventilator is vital. Too little exhaled carbon dioxide can cause the blood pH to turn acid, lowering the pH below 7.35, which the blood is normally slightly alkaline. Too much exhaled carbon dioxide will cause blood alkalinosis, which increases the pH of the blood above its normal 7.35, being slightly alkaline. Either situation can cause respiratory distress and tissue damage over time. One example of where this can be a problem is, for instance, porters or guides on Mount Kilimanjaro who are used to going up to very high altitudes where the top of Mount Kilimanjaro only has half the oxygen content that you have at sea level. The result is people often try and breathe more rapidly, called hyperventilation, to get more oxygen, and that can result in the emission of too much carbon dioxide. And so what happens is their blood turns alkaline and they get very sick, what's called acute mountain sickness. So there's an example of where improper treatment of the carbon dioxide by the respiratory system can cause a serious, potentially serious illness and potentially evolving into pulmonary edema or cerebral edema, which can be fatal. So as I mentioned, we're going to discuss ventilators as a separate topic, just as oxygen concentrators and analyzers are going to be a separate topic, which we will cover tomorrow morning. So we're going to take a lunch break, and when you come back, we're going to cover Anatomy of Respiratory Systems PowerPoint, which will discuss the physiological structures within the lungs and how they're used for gas exchange of oxygen and carbon dioxide. It's important that you understand that before any oxygen therapy or ventilator therapy will make sense. And then immediately after that PowerPoint, we will launch into labs. We're going to have a suction pump, vacuum calibration, pulse oximeter calibration using manual finger sim pulsing, and you will be getting your assigned wind power analyzer units and applying serial number stickers, and then you'll get a chance to use them with our two oxygen concentrators. And we will schedule these 3 different activities because We only have 2 oxygen concentrators, and we have a limited number of pieces of equipment, so everyone's going to be exchanging these activities through the afternoon. Then tomorrow, we will cover oxygen concentrators and analyzers PowerPoint. Tomorrow afternoon, we'll launch into using oxygen concentrators to calibrate your wind power analyzers. And then we'll disassemble and reassemble some oxygen concentrators so you can identify the parts. And then finally, Wednesday morning, we'll launch into mechanical ventilation systems, and we will continue after that with further qualification and calibration of the wind power units using air and oxygen mix from the ventilators. So until we cover ventilators, you're not going to be able to calibrate these wind power analyzers completely, because we won't have the ability to reduce the oxygen percentage down to values of, say, 40%, 26%, 60%, and other values that we can achieve with air mixing. So that pretty much sums this up, and what we're doing for the next few days, and enjoy lunch.